Thank you so much for joining us. Thank you so much for joining us for this important discussion today. My name is Gul Saeed, and I'm a fourth-year PhD candidate at Yale University and currently leading suicide prevention projects in Islamabad. I'll be co-moderating our discussion alongside my colleague Essen. You want
Hello,
to?
hello. Hello, everyone. Hopefully, I'm audible. My name is Essen. I'm a PhD student at Oxford, and my work revolves around suicide and suicide prevention in the global south.
Right. So शुरू करने से पहले I'll give a brief background on why we're having this discussion today. Suicide in Pakistan is a serious public health concern, and it is also a very sensitive issue, often kept silent despite the growing number of cases. खुदकुशी पर खुलकर बात करना हमारी communities में काफी मुश्किल है. Maybe some of us or most of us have experienced this to some extent. और अक्सर लोग इसे ज़हनी सेहत का मसला समझने के बजाय personal कमजोरी समझते हैं, or that's the framing that's often used. Like, the reality is that suicide is a public health issue that cuts across social class, age, gender, and geography. Research in Pakistan is still limited, but what we know from existing data is there has been an increasing trend making suicide prevention more important than ever. आज हम यहाँ इसीलिए हैं कि सुसाइड के बारे में नैरेटिव को चेंज करने की बात करें, मतलब स्टिग्मा और फियर की बजाय we shift toward a more supportive and understanding focus. I'm excited to introduce our four wonderful panelists who bring diverse perspectives on this topic. First, we have Dr. Murad Moosa, who is a UK-trained psychiatrist and suicide prevention pioneer. He is a professor emeritus at Aga Khan University. We also have Dr. Tayyeba Kiran, who's a clinical psychologist and a suicide prevention researcher. She serves as the Assistant Director of Research and Development at the Pakistan Institute of Living and Learning. We also have Nayab Mir, who's a clinical psychologist, writer, advocate, and for inclusive trauma-informed, queer-affirming, and disability-just care. And finally, we have Fatima Yasmin, who is the CEO of Musavi, a legal expert in justice reform, human rights, and trauma-informed policing. Thank you all so much for joining us for this discussion today. So just before we get started, for the audience, some things to keep in mind. अपना microphone please mute रखें unless you have to speak. Please save your questions till the end. अपने questions को कहीं note कर लें, as at the end there is a dedicated Q&A session. And then finally, this is a sensitive discussion, so if at any point you need to step away and take care of your well-being, please feel free to do so. चलें फिर शुरू करते हैं. So yeah, I'll start off with the first set of questions, which will focus on challenging the harmful myths and stigma around suicide in Pakistan. So my first question is it's in two parts. So I'd like to ask the panel, आपने अपने काम में या एक्सपीरियंस में सुसाइड के बारे में कैसी स्टोरीज या नैरेटिव सुनी हैं, स्पेशली उन लोगों से जो इस इशू से खुद गुजरे हैं? और ये जो लिव्ड एक्सपीरियंस वाले नैरेटिव्स हैं, ये किस तरह डिफरेंट या सेम लगते हैं compared to the policy, clinical या media narratives we hear in Pakistan? Does anyone want to get started with that one?
I can go.
Yeah.
Okay, so I think, okay, so in my practice, like as a clinical psychologist, like sometimes we come across like a lot of high risk cases where there's like active self-harm and like suicidal ideation, right? And I think there's like a lot of stigma attached to it first because all these people, they are always like, oh my God, like I don't want to be like a bad person. And if I'm having like any kind of suicidal thoughts, then I cannot talk to anybody about it because then people get worried and then, I don't want to be a burden. And like sometimes people just outright dismiss that conversation because you tell somebody, कि, zindagi अच्छी नहीं लग रही and, it's better to just end it. Then people usually respond to it as, nahi, you have like, look at the people who have so much, like, look at the bright side, look at the people who have like, जिनके पास एक कुछ नहीं है. So, and that comes off as like very dismissive to a lot of people because it shuts down that door of conversation. Because if I'm, I go up to somebody and I'm like, oh, I want to like, kill myself or I want to unalive myself. And the first reaction that I get is, no, but your life is precious, like look at the people who are doing like more horrible than you. It just shuts down that door of communication because then I'd be like, Okay, I mean, I get it, but okay, like what about my feelings? Like what about my emotions? So that is something that I've observed. And I think another thing that I've observed like within the mental health community is a lot of practitioners or people who are like in mental health fields, they're very scared to having like very open conversations about suicide or about even self-harm, because they're like, oh no, we cannot deal with it. And the third thing would be like the confidentiality issue, because we have to sometimes breach that confidentiality and like tell a safe person, and usually like family is the problem, or there is no safe person around them. So yeah, I hope that answers your question. So.
Yeah, it does. Does anyone want to add to that? Yes, Dr. Tayyeba, go for it.
Thank you, Gul. I totally agree to what Nayab has just said. But in my research work, the first narrative that we listen from both the lived experience experts and their families is sort of portraying the self-harm and suicidal behaviors as an accidental act. And then, obviously, after the confidentiality reassurance, there is a lot of difference between the narrative that comes from these survivors as well as the narrative that comes from the families. So the people with who like come who presents with self-harm episodes or suicidal ideation, they often talk about isolation, the feeling that they are being judged rather than obviously being supported. On the other hand, families usually tend to explain these acts of self-harm and suicidal behaviors as a weakness of faith. इसको तो अल्लाह पे यकीन नहीं है, इसको यकीन नहीं है कि अल्लाह ये चीजें ठीक कर देगा, या एक sort of आजमाइश, a test from Allah. We all know sometimes people also talk about influence of external forces के ये तो बिल्कुल ठीक थी या ये तो बिल्कुल ठीक था, लेकिन इस पे शायद किसी चीज का साया हो गया. If we talk about the medical aspect of this, it's still very biomedical and risk focused. At times, with limited attention being paid to a lot of social aspects of self-harm and suicide, like a lot of interpersonal difficulties at different levels, financial hardships, displacement that we all are witnessing these days due to these massive flooding across Pakistan. And you also mentioned the media, role of media. Unfortunately, the narratives are often very sensationalized, and this is something that not only increases the stigma, but this also discourages people from help seeking and health seeking. So yeah, there's a lot of gap between the narratives coming from patients, families, clinical experts, and then the media of things. Thank you.
If I could add to this very briefly. So from my experience as a legal practitioner, I think a lot of people that we engage with, including domestic violence survivors or survivors of, serious sort of crimes against them, I think one of the things that we have experienced is where there are thoughts of suicide or self-harm, there's already a lot of self-blame, that we hear in the people that are talking about it or recalling attempts. And of course, they're not reaching out to us for the psychological or the medical support. They are thinking about, a larger dispute, whether it is, getting out of an abusive relationship and what the legal remedies for that would be like. And, this comes as part of the story of the challenges that they're facing. So I think it's really important to keep that in mind, because many people that are struggling with these things are part of the same society. that stigmatizes these conversations, and many of them are conflicted about their own relationship with, religion or, honor or whatever is expected of them that they are not doing. So there's a lot of conflict. And I think this is something that we have observed, that there's a lot of self-blame as well, which I think is just a very vulnerable state to be in. And if you don't get the right kind of trauma-informed support at that time, but more stigma and more judgment from the people that you're talking to, I think people are just further and further away from, that conversation, even that conversation of trying to get some help. So that's just a perspective that I wanted to add here. And I think I also went through your research, yours, Gul and Ehsan, a paper that you wrote on qualitative aspects of, kind of looking at stigma. And I think it's also really important to, what you also flag out is that the focus in mainstream conversation is about the individual and personal traits. You have low resilience, you're a weak person, you have this, mental or physical condition that makes you vulnerable. And there's very little focus on the systemic drivers. What's the context? What are the problems around us that are, putting people in these states? Do institutions have a role to play? Does the state have a role to play? There's a range of factors which I think are more systemic in nature that make people vulnerable. And I think that perspective is really missing. And so I just also wanted to put that out there.
Yeah, thank you so much. So you all briefly touched on this, like about help seeking. Just to like specifically focus on that, how do you think that these narratives that exist out there, how do they influence help seeking behaviors among people who are experiencing suicidal ideation or behavior?
So if I can just come in there, Gul, if you don't mind.
Yeah, of course.
So, you'd also asked about the narrative that we hear. How does it sit alongside policy, clinical, and media context? So I'm sad to say that there is a total disconnect between what we find in the clinical setting, what patients and the families tell us, and what we may read in policy. Well, there is no policy, or even in the media, which seems to be the most important driver of public opinion in Pakistan, it seems. And if I just focus on the suicide, the psychological autopsy study that I did, which has been quite a few years now, it was really interviewing key informants of the victims of suicide. And the thing that comes through over and over again in all the cases that I interviewed 100 cases, it was a case control study, was that they didn't know. One, they didn't know what the person was going through. And second, even if they did know, even if they suspected there was something wrong, something had happened with the person had changed, they didn't know where to seek help, who to go to, where to access help. So these were the two themes that really came through. One, they did not know there was anything wrong. And I guess what the others have touched upon, guilt, shame, maybe kind of highlighting religious, strengthening your religion and so on and so forth. But the most important thing was that they didn't know that it was so deep. And the second is, even if they did find where do they seek help? Who do they go to? And that really reflects the systemic issue that just been highlighted, the absence of, say, a public-funded health system, which we don't have in Pakistan, which is the first port of call for systems and societies where there are good health systems. So you'd go and contact your health provider. It may be a GP, it may be a community nurse, or maybe a crisis center. So that is very important as we talk about people talking about how to seek help and where to seek help, and then. The second barrier comes is even if they are directed, signposted to some place, can they actually afford it? And then there's another barrier. Even if they do reach a mental health expert, what kind of expertise and background do they have? Will they be able to do what is called narrative interviewing, for example, of these people? Or they will be focusing on a checklist of risk assessment, which are totally irrelevant in the context of Pakistan. So there are many, many barriers. Some are systemic, some are individual barriers. But I think we really need to look at all the different areas and levels where we talk about. And when we do come up, hopefully with a policy, it really should reflect what people are saying. And that really comes from really listening to people who have gone through the experience, either the patient themselves or the families. Thank you.
Yeah, thank you so much. I just see a request in the chat कि उर्दू में बात करें, so let's all just try to, use a little more Urdu in our conversation today. Or someone's raised their hand. Please अपना question end तक note कर लें. End पे Q&A session होगा. Please kindly mute yourself. Thanks. Okay, so मेरा अगला सवाल ये है कि आप सब इस फील्ड में काफ़ी सालों से काम कर रहे हैं. आपने इस टाइम में देखा है कि टाइम के साथ पाकिस्तान में खुदकुशी के बारे में बात करने का तरीका बदला हो. So has there been any change over the years in the narratives that we hear about suicide?
I think one thing that I can add to it is the fact that for like the longest period of times, like suicide has been criminalized. उसको हमेशा एक criminal उसकी नजरों से देखा गया है. And I think it wasn't until 2022 में there has been work to like decriminalize it, like at least on paper. But like the attitude is like still very much same as it used to be before. The only thing that has changed probably is कि अब ज़्यादा लोग आते हैं to us, even like to therapy, or they have at least some kind of space. लेकिन फिर I would still say कि whether or not it is affordable, or what kind of people, like do they belong to a certain class, because obviously अगर पैसे हैं तो you reach out to a mental health practitioner. अगर पैसे नहीं हैं तो the quality of the care that you're receiving, that is also kind of वो dull down हो जाती है, because it's like usually the people who are not trained, and if you are trained, then more mental health practitioners वो पैसे ज़्यादा charge करते हैं, and it is like around 5,000 like over that per session, और वो बहुत difficult हो जाता है. And there was this person, I was talking to this person, and they were like, oh, I tried to like reach out to जो free helplines होती हैं of like suicide prevention, लेकिन उन्होंने उधर लिख के लगाया होता है कि जी 9 to 5 हमारी timings हैं, and they were like, okay, अगर 5 बजे के बाद emergency है तो फिर क्या करें. And there was this one time where this person was really struggling, और उन्होंने call की, उनके पास balance नहीं था, and they just started laughing like, oh, why do you need mobile balance in order to call the suicide prevention helpline, because it doesn't make sense. So as somebody also mentioned before, there is like a lot of barriers and attitude. I think change ho raha hai, but it's not enough, because it's very complex. It's the systematic oppression wali cheez aati hai, because we focus like so much on कि ओ हमारे अंदर मसला है, like the person who is struggling, उनके अंदर इशू है, जैसे आपने बात की कि like resilience नहीं है और जो भी है, but we don't look at the systems that are in place. It's the same thing with depression, कि हम उसको बहुत pathologize कर देते हैं कि okay, it is a disease and you need to work on this, or like दवाइयाँ ले लो और ये ले लो, but जिसकी वजह से हो रहा है, we do not really fix it. That is poverty, that is abuse, that is like a lot of violence that is coming from in interpersonal relationships, yeah, state level violence, or we don't really get to that point. And yeah.
Yeah, Dr. Tayyeba.
Thank you, Gul. Again, yes, कुछ change है over time. But I agree, change बहुत slow है. It's very uneven. Let me give you an example. There was in time, ये कोई बहुत पुराना time नहीं है, almost a decade before, जब universities and colleges, schools को approach किया जाता था for mental health awareness programs या suicide prevention awareness programs. तो schools, universities reluctant होते थे कि उनकी space को इस्तेमाल किया जाए for such events. Mental health के लिए generally और self harm and suicide prevention awareness events के लिए particularly. But this year already जैसे हमें from platform of Pakistan Institute of Living and Learning हमें काफी यूनिवर्सिटीज ने स्कूल्स ने अप्रोच किया कि सुसाइड प्रिवेंशन डे पे अगर स्टूडेंट्स के लिए और टीचर्स के लिए कोई अवेयरनेस प्रोग्राम अरेंज कर दिया जाए. अगेन जो हमारी एकेडमिक प्लेसेस हैं, हमारी क्लिनिकल स्पेसेस हैं, उस पे हमने वी हैव started talking about self-harm and suicide as public health issues. बहुत सारी organizations हैं, there are sport groups, particularly youth sport groups, जो mental health advocacy पे काम कर रहे हैं. They are creating conversation. Social media का भी इसमें रोल है. But जैसे नायाब ने भी कहा कि if we talk about families, if we talk about our communities, वो stigma is still there and stigma remains very strong. अभी भी जब हम किसी फैमिली में कोई ऐसी न्यूज़ सुनते हैं सुसाइड की, तो खुदकुशी का लफ्ज आमतौर पे कम इस्तेमाल किया जाता है. बहुत हो जाता है तो हमें ये सुनने में आता है कि वो बहुत मुश्किलात से गुजरा था, मुश्किलात को बर्दाश्त नहीं कर सका तो इस दुनिया से चला गया. तो फैमिली और कम्युनिटी के लेवल पे स्टिल बहुत स्टिग्मा है, बहुत कम बात की जाती है. बट कुछ चेंज है. अगेन चेंज स्लो है, अनइवन है, बट चेंज है. थैंक यू.
Sir, if I can just add to that, because स्टिग्मा की बात हो रही है. ये देखिए, स्टिग्मा को आप आइसोलेशन में नहीं देख सकते हैं. स्टिग्मा को जो माशरा है उसके कॉन्टेक्स्ट में देखना बड़ा ज़रूरी है कि जो हमारा माशरा सोसाइटी है किस लेवल पे फंक्शन कर रहा है, एजुकेशन लेवल कितना है, अवेयरनेस कितनी है. सो कुछ भी, कोई भी चीज़ हो, ट्रैफिक के लॉज हो या मेंटल हेल्थ की बात हो रही हो या कोई भी हेल्थ इशू की बात हो रही हो, अगर आपकी सोसाइटी उस लेवल पे पहुंची नहीं है तो ये चीज़ों को यू कांट एक्सपेक्ट दीज थिंग्स टू इम्प्रूव. And therefore, the whole society has to lift to be able to address these really critical and very, very sensitive issues like suicide, which is an extremely sensitive issue क्योंकि उसके जो जो पहलू हैं मज़हब के साथ उसका है, सोशो कल्चरल एस्पेक्ट इसके साथ है, फैमिली ऑनर के साथ है. तो ये एक्सपेक्ट करना कि ये इसमें स्टिग्मा ख़त्म हो जाएगा, ये बिल्कुल this will not happen. And we have to live with that, and we have to find solutions how we address this issue while having these really very, very deeply ingrained barriers within the society. And therefore, the language has to change. The words that we use, खुदकशी हम बात इस्तेमाल करते हैं या hopelessness की बात करते हैं. If hopelessness within depression is the critical factor that leads people to self-harm, then what about the hopelessness at a societal level, where people feel completely hopeless, young people feel hopeless, young people feel no hope in the future, the way the country is being run. So we have to see then, is the society itself on a suicidal pathway? So ये stigma की जब हम बात करते हैं, we really have to take this wider issue of what is happening in the society and not just focus on the individual. I just wanted to make this point कि society को we should not forget the society that we live in. Thank you.
For sure. Actually, that leads into my next question. So my next question is, हम अपनी language और approach को कैसे adapt कर सकते हैं जब हम suicide के बारे में बात करें, ताकि पाकिस्तान के cultural and religious values के साथ align करें और हम stigma ना reinforce करें. So are there any like strategies या कोई तरीके आपने अपने work में, research में, or you know, practical experience में encounter किए हैं?
So if I can just follow on from what I said earlier, देखिए ये the approach has to be a joint approach. Every patient, every client that you may see in your setting will come from a very different background. उनका socio-economic जो background होगा, उनका education level, वो जो लेंस जिस तरीके से चीज़ों को देखते हैं वो बहुत डिफरेंट होगा. वो समझना बड़ा ज़रूरी है. एंड देन जॉइंटली आपको एक्सप्लोर करना पड़ता है कि उनका एटीट्यूड क्या है, उनकी नॉलेज क्या है, किस तरीके से उस चीज़ को देख रहे हैं. एंड थ्रू दैट एक्सप्लोरेशन यू हैव टू ट्राई एंड फाइंड अ मिडल स्पेस. And the language comes through that. So language, sometimes they are comfortable talking, using the term suicide. Other times they may be very, very uncomfortable. Uske liye aap terms like bezari, bebasi, helplessness, hopelessness might be a term that they may indirectly be talking about. So it really requires you to sit with the person, explore, find out really where they are coming from, उनका अपना क्या एक रवैया है, इसके बारे में क्या सोच है, and then very gently and slowly try and discover this middle space, and the language will come from there. But the important point is this takes time. This takes experience on the part of the therapist. It requires a lot of patience and the ability to hold on to your own anxiety, which obviously, when the patient comes in and burden themselves or the families, your anxiety level goes up. A tendency, whether it be a psychiatrist or psychologist, particularly if you're a psychiatrist, is the tendency is to reach for the prescription pad and prescribe. For the psychologist, it might be something else. It might be that you want to curtail the interview as soon as possible or distract them or so on and so forth. So training and experience is extremely important. A joint approach in which you are exploring the area with the patient or the families together, and the language will come from there. It cannot be a prescriptive coming from a top-down approach where we feel we are the experts and only we can understand what needs to be done. Thank you.
If I may add here, so I think that, of course, just echoing further what Dr. Murad has said, I think it's also really important to understand that we need to also destigmatize related language, right? Like, for example, sure, suicide might be the one that carries the most stigma, but is it okay for people to, be unwell, and access mental health? Even mental health is stigmatized in many parts of the community. To be able to say that you need, support because you're undergoing something, carries a lot of stigma in certain communities at scale. So that also needs to be destigmatized to be able to find the appropriate language. So we don't use suicide, we say this person is, is suffering from a health issue. Is it okay in society to have a health issue in certain contexts? For example, is it okay to be someone who's not strong in the traditional sense of whatever is expected of certain roles? Like, men are supposed to be certain ways, women are supposed to be certain ways in certain situations. And if they don't align with those roles because of patriarchy or other societal expectations or ideas of honor or ideas of religion, then, there's layers of stigmatization. So you could escape one and then carry, the next set of words would carry their own set of connotations. And so I think in order to have that holistic impact, we do need to go deeper to see what are all the different, steps before we come to the place where, where we're talking about suicide being, maybe the last part that we want to be able to avoid or prevent. What is before that is also controversial, is also stigmatized in terms of at the family level, at the community level, at the institutional level, in the way that we talk about certain things, in the way that we expect people to talk about those things, whether people are even able to, speak in certain terms in a societal or institutional context. So I think that that perspective, I think, is important. And I do think that we do have a lot of inward looking to do at the systemic, aspects of what creates an environment where we create this stigma, and what is in the language that is problematic, by decoding it further.
Can I add
Thank you.
something to this
Yeah, go
really
for it.
quickly? Oh, sorry, Gul. Okay, so I also think one of the two things happen when a person bring up any kind of suicidal ideation or thoughts. हमारा पहला reaction is that intense level of discomfort because हमने वो stigma इतना internalize कर लिया है, right? And I'm talking in the context of like mental health practitioner or just, general public or, friends or anybody. And I think the first thing would be to sit with that discomfort. Okay, why are we dodging to, have like conversations? Like, why are we too scared to, say it or like call it like suicide or like call it khudkushi or suicidal ideations. And दूसरी चीज I think जो होती है that is हम फौरन we go into like the savior complex mode, right? कि हमने इनको बचाना है. And every time we, like, for example, if somebody comes to me and I am so uncomfortable with it, and I feel like "Nahi, I need to be like, I need that, I will take on to that responsibility to save this person." That is the point where I stop thinking about the other person and I'm making it about myself because I cannot sit with that discomfort. I cannot take that responsibility of another person. Or वहां पे फिर you're not thinking about the other person, you're thinking about yourself and like how can you ease your discomfort. So the conversations need to be centered on the person who's having any kind of suicidal ideation, and the point is कि हम उनको space दें, while simultaneously working on ourselves, like where do our savior complex comes from, right? And I think in mental health field a lot of people like we I've been there, done that, right? But I had to like do a lot of inner work. Okay, I cannot save this person, because if you end up losing that person, then it's a lot of guilt that comes with it, and it impacts like you as a person as well, and you as somebody who is providing that care. So yeah.
All right, thank you so much. This we'll get moving on to our second objective. Over to Essen.
So we'll be shifting gears a bit. We'll be shifting towards our second objective, which is a more holistic understanding of silence. And I want to just build on to what we've already been talking about. A lot of my work and a lot of Gul's work also centers this idea of intersectionality, which for our viewers is the idea कि आपकी different identities, आपका age, gender, ethnicity, religion वगैरह सब interact करती हैं आपकी experience shape करने में. So the question really here is that, you know, all of our destigmatizing campaigns, they're often focused at individuals who might have access, right? There will be people who can afford it, can come to a private hospital. So the question here really is, who are we missing out? And Nayab, I know a lot of your work also centers around this, so perhaps you can start. Who are we missing still in the Pakistani context when we're talking about suicide and silence?
Okay, thank you for posing that question. You asked, and I was like, yes. Okay. So I think one of the experiences that I can share here is the queer community and people who are extremely marginalized. It can be other minority groups, like based on religion, based on gender, sexuality, that are currently living in Pakistan. Because पहले तो they are facing the stigma of their sexuality, gender, and their religious identities, and on top of it they're also dealing with the stigma of being suicidal in that space. And there was this one time where I was attending this like training thing, and I ended up like almost blowing up on them. Okay, so they were from, and it was like for like a suicide prevention training program, and they were training us, and they were like, oh, it's okay if you guys, that's not exactly what they said, but it was something along the lines of, okay, it's okay if a queer person comes in and like you are not comfortable with it, so like you can tell them to like call later. And now look, suicide, if anybody is experiencing any kind of suicidal ideation, you need to intervene like immediately. You cannot deny access to care just because you might be uncomfortable, or you might be biased towards somebody's like sexuality and gender, or the kind of religion that they belong to. So these kind of things unfortunately exist. And the more, at the lower level of hierarchy, the more intersections of it can be like class, it could be gender, it could be any kind of disability. The more intersections of these things you have, the more you are likely to go down that road where you are experiencing a lot of like oppression, right? And those are the people who there are a lot of barriers when it comes to accessing, because it's just not one layer of stigma. It's like stigma over stigma over stigma, and that access of care. A lot of times we talk about how, you know, for example, if I talk about conversion therapy, that also increases, the risk of suicide, but we still do it because a lot of people, it's very common in Pakistan. And even though there are researchers that say, oh, it increases the risk of suicide, um, we are operating from a place of like very deep and inherited bias, not caring about whether or not somebody's like suicidal, specifically talking about like within the queer context. And other than that, like I think mental health is always political, and like gender affirming care, even using like pronouns, like somebody's correct pronouns, it's also suicide prevention. Housing, reducing poverty, that is all suicide prevention. But as so many people said, okay, we are just focusing on the individual aspect of it, and now how systems interact with each other and form more complex layers. So I hope that answers your question.
Would anybody else like to add on to that? The intersectional nature of stigma?
I think if I can just ask about a group that doesn't really think enough about it, are institutions that are directly responsible for first response in many cases, or do extremely stressful work that exposes them to a lot of traumatic situations. So, for example, in the context of police, we did an engagement with them on trauma-informed policing, which of course has two components. One, of course, is how do you provide support to the most vulnerable that you're engaging with, complainants of all kinds, which includes, as Nayab mentioned, these various groups that, can just be more and more vulnerable depending on the layers of vulnerability that are attached to them, whether it's disability or identity, etc. But the second part of it is how seriously does an institution take mental health with regard internally. So, for example, people within the force, that are directly engaging at scale with, complainants and survivors, are they experiencing, suicidal thoughts? And we have heard, people talk about it, that it does become that way. And whether institutions are firstly open to having those conversations, there is also a stigma associated to a certain profile of an institution that is supposed to be providing something, to be going through something like this. But I think effectively to be able to provide that care, you need to have a culture within the institution to provide that care to the first responders themselves. So one of the things that we think is extremely important, and we've tried it a little bit with the police, is to start having that conversation of what it means to provide that support to, people that are on the front lines, that are interacting with people to be able to navigate these things. Another group I think is also important, and I think it was a delayed realization on my part, on part of our team, is people that are working with survivors of serious sexual violence, healthcare workers, but also social workers, women protection officers, litigators, lawyers. We're not trained to process that scale of information, because we're not medically qualified in many situations, which I think is also something to think about for practitioners that do engage with this group. But at the same time, I think many of people in such positions also experience vulnerability, I think, to for their mental health, but also in an extreme form, it can escalate without any sort of identification and internal thinking about what's kind of happening to you. And it's not a conversation that we're having, that whether or not that kind of support is needed as well for certain groups that engage on the service providing side of things. Yeah.
Thank you so much, Fatma. And I think somebody also mentioned in the chat, like there's so many groups that are so vulnerable. Somebody also mentioned people who are suffering through addiction and substance abuse, right? They're also like very much blamed and have these layers of stigma. Dr. Tayyeba.
Thank you, Ahsan. Sit briefly, दो points add करूंगी. One very important aspect, जो I think we should not forget, is the geographical disparity. हमारी urban settings, we know awareness is gradually increasing because the exposure to education, exposure to media, uh, exposure to all these advocacy campaigns is increasing. Though silence is still there, though stigma is still there. लेकिन हमारे जो रूरल एरियाज हैं जहाँ सुसाइड के बारे में बिल्कुल ओपनली बात नहीं की जाती, जहाँ बहुत एट्रीब्यूशंस हैं टू किस्मत, इसकी किस्मत ऐसी थी इसलिए हो गया, स्पिरिचुअल वीकनेस थी, या अगेन वही एक्सटर्नल फोर्सेस का कॉन्सेप्ट। तो इस जियोग्राफिकल डिस्पैरिटी को हमें जरूर जहन में रखना चाहिए, बिकॉज रूरल एरियाज में वो साइको सोशल स्ट्रेसर्स वैसे ही मौजूद हैं, शायद ज्यादा ग्रेविटी और मैग्नीट्यूड के साथ मौजूद हैं। दूसरा बहुत इम्पॉर्टेंट ग्रुप जिसके बारे में बात करना जरूरी है इज पीपल विद कोमॉर्बिडिटीज, जैसे क्रॉनिक फिजिकल हेल्थ कंडीशंस हैं। मैं जरूर बात करूंगी ब्रेस्ट कैंसर की, जहाँ कोमॉर्बिड डिप्रेशन बहुत हाई है और एक्सेस टू केयर बड़ी लिमिटेड है। तो उन ग्रुप्स को के बारे में बात करना भी आई थिंक बहुत जरूरी है, बिकॉज वहाँ ये होता है कि ऑटोमेटिकली हमारा फोकस जाता है फिजिकल एंड मेडिकल हेल्थ कंडीशन पे, और मेंटल हेल्थ और स्ट्रेस की बात बहुत देर से आती है। तो आई थिंक वो एक ऐसा ग्रुप है जो एक प्रायोरिटी ग्रुप बनता है। आई विल पॉज हियर, थैंक यू।
Thank you so much. And I find very interesting that you bring up this idea of like spiritual weakness, or like, and there's a lot of cultural codes that we specifically have in Pakistan. My next question is about that, specifically honor. Suicide has this very tense relationship with religion and honor. So I'm just wondering how you have navigated, all of you have navigated that, and shifted people's, parents, especially parents who have it's young children who are experiencing suicidal ideation. How do we change their attitude from judgment to compassion in a culturally legible way? How do we manage to do that?
I think it's very hard to manage that when our systems are like so much rooted in patriarchy and misogyny, and racism, right? Sorry, what was your question again? I forgot.
My question is simply कि हम suicide के बारे में culturally legible ways में कैसे बात कर सकते हैं in a way that is in accordance with our cultural context.
Yeah. Okay. So I think uske liye we need to have like difficult conversations, like where is it coming from. And if we talk about like honor, then there are a lot of children who end up like getting abused, like sexually abused in the same house, but that conversation never happens because the parents know the abuser, and like unke liye rishtedariyan nibhana is more important, and family ko what do you call it, to preserve the family values, कि अच्छा लोग क्या कहेंगे, it's okay, आप चुप हो जाओ, and that silencing comes with a huge cost, because then again you are not centering the other person who's actually who's actually struggling. आप वायलेंस को सेंटर कर रहे हो, आप पेट्रियार्की को सेंटर कर रहे हो, आप मिसोजिनी को सेंटर कर रहे हो, और किसी it's very difficult because it's very complex, because if you need to talk about why women औरतों के अंदर डिप्रेशन और सुसाइडलिटी का रेट बहुत ज़्यादा हाई है। वेस्ट में आई वाज रीडिंग लाइक दिस रिसर्च वेयर इट वाज लाइक ओके, women or people with uterus, they have more suicidal ideation, but men are more likely to commit suicide. In East, it's opposite, like it's different, because women are more likely to attempt suicide. So like the research is kind of flipped here, because not only are they dealing with the mental health stigma, but they're also dealing with a lot of misogyny and a lot of violence, because the system is very patriarchal. So I don't think it's that easy to talk about suicide or like find very culturally relevant ways, because the culture is standing on a lot of abuse and a lot of silence. Because once you start talking about कि okay, I'm not gonna be silent, 6 लोग बैठे होते हैं आपको चुप कराने के लिए. So how can you navigate the system that is literally built on silence? It's not easy.
Ahsan, can I just come in here if you don't mind?
Yes, please go ahead.
So, हम suicide की बात कर रहे हैं, and if you look at the numbers जो इस वक्त हैं, हम तो खुद नहीं कलेक्ट करते हैं खुदकशी के जो statistics हैं पाकिस्तान में, so we don't know. We have to rely on WHO, World Health Organization की estimates पे. तो इनका जो लेटेस्ट अभी रिपोर्ट निकली है 2021 के फिगर्स उन्होंने कोट किए, 3-4 साल हमेशा पीछे होते हैं वो, उसमें पाकिस्तान में उन्होंने बताया कि 13,506 सुसाइड हुई थी 2021 में, जिसमें से तकरीबन 9,000 आदमी थे और 4,000 के करीब औरतें, लिटिल मोर लेस, वो आप रिपोर्ट देख सकते हैं. सो अगर इसको हमने कम करना है, इवन इफ यू बिलीव कि ये जो फिगर्स हैं ये सही हैं पाकिस्तान के लिहाज से, तो हमें एग्जांपल लेनी चाहिए कि दुनिया में बाकी जगहों पे क्या हुआ है, कहाँ पे जो नंबर्स कम हुए हैं. चाइना इज वन वेरी गुड एग्जांपल. चाइना वाज अप अंटिल 10-15 years ago सबसे ज्यादा खुदकशियां चाइना में होती थी, सबसे ज्यादा, नॉट रेट्स बट नंबर्स. और नंबर 2 पे इंडिया था नंबर्स के लिहाज से. रेट्स तो खैर वो ये छोटी यूरोपियन कंट्रीज में इनकी पॉपुलेशन बहुत कम है, इसलिए वो रेट्स ज़्यादा हो जाते हैं. रेट्स जो होते हैं हमेशा 100,000 के ऊपर आप कैलकुलेट करते हैं. लेकिन चाइना में वेरी ड्रामेटिकली ये जो नंबर्स हैं कम होना शुरू हो गए. और उसकी जो वजह है, इट इज़ नॉट कि मेंटल हेल्थ बहुत इंप्रूव हो गई है वहाँ पे, बहुत ज़्यादा साइकाइट्रिस्ट और साइकोलॉजिस्ट आ गए हैं, लेकिन वहाँ पे जो माशी एडवांसमेंट हुई है ना, द इकोनॉमिक miracle that has happened in China and the progress that has happened. The rural population, which was driving the suicide numbers in China, moved to the urban areas, and suicide numbers in young women in China have come down, and that has brought down the numbers of suicide in China. So आपको ये देखना होगा कि सोसाइटी लेवल पे अगर आपने सुसाइड को करना है तो आप किस चीज़ पे फोकस करें. इंडिविजुअल पे तो खैर कर सकते हैं जो हम अभी बात कर रहे हैं कि किस तरह आप डील करिए और क्या लैंग्वेज इस्तेमाल करिए और क्या करिए, लेकिन सोसाइटी लेवल पे बहुत ज़रूरी है कि इसको हमने मैक्रो लेवल पे देखना है, अपस्ट्रीम फैक्टर्स को एड्रेस करना है. और जो सोशल डेवलपमेंट है जिसके अंदर गुर्बत, जो बेरोजगारी है, जिसके अंदर हाउसिंग और लॉ एंड ऑर्डर की जो बातें हो रही हैं, और लोगों को सोशल जस्टिस नहीं मिल रही है, इकोनॉमिक जस्टिस नहीं मिल रही है, और आपको फाइनेंशियल जस्टिस नहीं मिल रही है. तो ये चीज़ें जब तक आप नहीं करेंगे, ऊपर वाली चीज़ें, नीचे वाली चीज़ें ठीक नहीं हो सकेंगी. उसके साथ एजुकेशन की आप बात कर लीजिए. लिटरेसी लेवल्स इतने अगर कम है तो कोई प्रोग्राम आपको बेहतर हो ही नहीं सकता है, चाहे वो फैमिली प्लानिंग का प्रोग्राम हो, चाहे मेंटल हेल्थ का हो, डोमेस्टिक वायलेंस का हो, या सुसाइड प्रिवेंशन का. So at a society level, we have to really address these issues, and all mental health advocates should learn the language of moral courage, to be able to speak truth to power, not stand and have your photograph taken with the Minister of Health of Sindh, because they are responsible for creating the condition that is driving the mental health and the societal crisis in Pakistan. लेकिन तस्वीरें खिंचवाने का हमें बहुत शौक है, लेकिन हम उनको कभी वी डोंट होल्ड देम responsible for the condition they are creating. So we as mental health advocates जो हैं, we should learn how to speak up and speak out for the vulnerable, and hold these people who really hold the purse strings to solve these problems. We are very happy to produce evidence which they can use, but they have to really come up with the answers. Thank you.
Thank you, Dr. Murad, and that was really profound. We've had conversations about this, how, ultimately, suicide is a political issue, especially in Pakistan, and that brings me very nicely into my next question, which is, who do we and how do we hold people accountable? So we've talked about how there's this political system, there's so many structural factors. What are the different levers? Whose cooperation do we need to change this in Pakistan? And
If
how
I
does one go about doing that? Yes, please go ahead.
if I can start with this, अगर हम section 325 से शुरू करें जो 2022 में has led to decriminalization of suicide. लेकिन अगर आप उसके बाद भी देखें, which we know from our partners in Sindh telling us there's still cases pursuant to section 325 ongoing. Punjab mein we also know from our experts that there are still some cases that are still there. पाकिस्तान का ये एक मसला है which is not limited to this amendment. Generally भी जब भी laws आते हैं तो it's not obvious कि सारे जो institutional actors हैं या जो भी public at large है उसको पता हो कि ये change आया है. And we usually do not leave that level of resource कि वो हम mass dissemination कर सकें. Do we build capacity of सारी institutional actors जिन्होंने उन चीज़ों को implement करना है. And this is something that we see also in the case of the gaps in the implementation of the decriminalization of suicide change. 3 years later, we're in 2025 now. So I think thoda sa, one of the things that we also have to think about is how do we build in this transition space? कि जब भी कोई law आता है, तो how do we, build in resources and time and energy to build capacity of everyone to know about it, to be able to implement it, which requires specialized trainings for many of these actors. क्योंकि policing का काम अगर पहले FIR काटना था, when they were reported a case, now they're supposed to be providing care. They're supposed to be making referrals. Similarly, अगर health officials were supposed to inform the police the moment they got to know about a case of self-harm, now they're supposed to not do that because, the police's domain is completely different than what it used to be before. And I think so we cannot assume, with a legal amendment, that these kind of changes are naturally translating. I think now is really the time and the opportunity to have those conversations and really cement some of that change. And similarly, of course, awareness that we need to have on it as well. Having said this, यहाँ पे ये भी है कि laws, even if we improve them, it's not always linear. You can always go back. That's always a bit of a tricky space. We do know there is a petition pending in the Federal Shariat Court, which is kind of like a hanging. My personal opinion is it hasn't been taken up. Maybe it's not meant to be taken up. This is kind of somewhere. Sometimes things just stay there for a long time. Having said this, it's still there. So we need to continue to have that conversation that you were saying, how do we build a larger consensus in society? This is important, there are different dimensions to it. This is not a religious issue. And build that at scale movement against something like this. So that's one thing. But also when we look at, building capacity, we also need to look at capacity of judicial actors. Jaise maine kaha, kuch cases jo purane hain, they might still be in different stages of the judiciary and the prosecution, etc. And families are still, kind of in that situation of, actually dealing with the real-time consequences of what penalization leads to as well. So we need to dismantle some of the old system, which is very much still there in practice for people to be able to really, kind of start having some semblance of change that, you can kind of build on. In addition to these larger conversations that are also important. But I think a multi-sectoral approach is essential. Lekin usme jo sare actors hain, they need to reframe their position. And I think the last thing I want to say about this, I think hamari mental health mein jo investment hai is, dismal, right? It's like, and I think there are best practices in countries. For example, in Japan, I think the number of suicides decreased with the amount of, spending increase in mental health. Similarly, there are best practices to show that decriminalization in itself is supposed, if it's implemented correctly in a way that allows people to report and seek care by a system of support, does reduce, instances of suicide. We've seen that in Sri Lanka, we've seen that in Singapore, post decriminalization. And I think I think there's a research of 171 countries which shows a direct relationship between decriminalization of suicide and suicide rates, that it basically, criminalization leads to increased suicide rates rather than the opposite. So I think thodi si evidence-based messaging in the society, I think culture is important, but I think culture doesn't always need to be everywhere, right? Where there's research to show, there's scientific evidence to prove something, that information needs to be there. And I think, of course, it's linked to the educational abilities of the society, but we still need to engage with those more than just, we're not culturally ready for something which is a medical fact, you know. I think thoda sa we need to dispel those ideas.
I
Thank you.
think
Thank
I
you so
would
much,
like to,
Fatma.
yeah.
Yeah, go ahead,
I would
Nayab. Go ahead.
like to add something to it. Thank you so much for having this conversation. But I also think one of the things that we can do is to just keep talking the truth, right? Like if you're authentic in how I know it's very difficult because I understand there's like a lot of stigma. But a lot of times when we're so openly talking about mental health struggles or we're talking about suicide, just putting ourselves out there gives a lot of courage to a lot of people to open up that dialogue. And people sometimes like look at us and they be like, okay, you said something, or like you are so open um about things, that it also gave me a courage. So it doesn't like exist in like silos. We also give that courage to each other. And I think we need more safe people. We do need more safe spaces, but we also need more safe people. And other people knowing that like दूसरों को बताना भी जरूरी है कि okay, I'm a safe person. And the best way to do it is to show up as your authentic self. You don't have to be perfect, you are human. Because I think therapist से normally expect किया जाता है कि okay, आपकी तो सारा like sorted होगी आपकी life, like you would be emotionally आप सारे sorted हैं. Because obviously psychology पढ़ी है, but there's also room for a lot of your own humanity and a lot of your lived experiences. So keep talking. Never stop. And कभी हमें लग रहा होता है कि यार क्या फर्क पड़ेगा, like I'm just one person. um but it could end up saving somebody else's life, or give them the courage to take a stand for themselves. So I think that is also very important. And I also agree with Fatma completely that since suicide only got recriminalized in like 2022, उससे पहले का भी हमारे पास डेटा भी उतना इतना ज्यादा नहीं है. Because जो केसेस होते हैं और जो हॉस्पिटल तक पहुंचते हैं, दैट्स लाइक you do like a suicide attempt and then you go to a hospital. There are so many cases where there are active ideations. Yeah, you do not get to the hospital. Yeah, like hospital wale are covering it up because they're like, oh, police case ho jayega. Yeah, sometimes they could also deny help, right? So yeah, we really need safe people and safe spaces.
Thank you. Thank you so much for sharing that, Nayab, and thank you for trusting us with that information. I am mindful of time, so we'll move on to the Q&A from the audience. I know a lot
Yeah.
of people have had their hands up. Gul, go ahead.
Yeah, I'll get started. I know we'll start off with Dr. Rana. You had a question at the start. If you want to unmute yourself and ask. Okay, maybe he's gone. Okay, in that case, I'll get started. There were several questions in the chat. So one of the first questions is about non-suicidal self-injury. What are the reasons people engage in this behavior, and does it increase the likelihood of a future suicide attempt?
I can take that. Okay, so a lot of times it could, but also it kind of like depends on the context. Because usually if somebody is committing self-harm, zaruri nahi hai कि in the back of their mind it's like, oh, I want to like, end my life. But sometimes it's more about, having that emotional release. Because when you're self-harming, then there's like, you have it's painful, right? So आपकी जो emotional pain होती है, that gets like distracted. So more you kind of like switch to physical pain, and ताकि आप emotional pain से आपको like थोड़ी सी release मिले. Sometimes it does increase the chances, but not always. There are like so many things attached to it कि like for sure नहीं कह सकते कि अगर कोई self harm कर रहा है, then that also increases the chances of suicide. It could, but it also like again it depends on the context. And I think self-harm ke saath bhi there's a lot of stigma. Because in the mental health community in Pakistan, normally you talk about self-harm or आप psychiatrist ke paas जाते हैं and they're like, oh, borderline personality disorder, and they put you on like antipsychotics. But that is not always the case. um it is seen, it is very common in depression, it is very common in complex PTSD, it is very common in any kind of like neurodivergence, autism, ADHD as well. But the goal is to release some of the emotions, right? And how we navigate through that is to giving them like ek pehle to like exploring it and not dodging the conversation, okay, because it's like obviously very uncomfortable to sit with, right? So yeah, I hope that answers the question.
Yes, thank you so much.
Gul, I can also see Uzma Banu has her hand up. Uzma, go ahead.
जी मेरा क्वेश्चन ये है कि किस तरह आइडेंटिफाई करें एक लेमैन अपनी फैमिली में, फ्रेंड्स में, दैट्स somebody is moving towards suicidal thoughts. अगर डॉक्टर मुराद इसका जवाब दे सके तो वेरी गुड.
देखिए, ये जनरल मैं आपको जवाब दे सकता हूँ क्योंकि केस टू केस वेरी करता है, लेकिन कोई भी आपके फर्ज करिए घर वाले हैं या आपके करीबी दोस्त हैं या काम के साथ कोई कोलीग हैं, अगर उनकी जो एक जिस तरह से आप उनको जानते हैं या जानती हैं नॉर्मली, किस तरह वो बिहेव करते हैं, किस तरह रहते हैं, उठना बैठना कैसा है, बातचीत कर, उससे अगर हट के कुछ चीज़ उनके साथ हो रही है और वो चीज़ वक्ती नहीं है लेकिन कुछ अरसे के लिए चल रही है, खामोश हो गए हैं फर्ज करिए बहुत ज़्यादा, या अपना हुलिया जो जिसका बहुत ख्याल रखते थे वो इतना नहीं ठीक से देख रहे हैं, खातून है मेकअप नहीं कर रही हैं फर्ज करिए, या बहुत लेट आ रही हैं या लेट आ रहे हैं, तो जो उनकी नॉर्मल एक बिहेवियर है जो लाइफ है उससे अगर हटके कुछ आप देख रही हैं और वो कुछ अरसे तक चल रहा है, तो, तो वो एक रेड फ्लैग होना चाहिए कि कुछ इनके साथ हो रहा है, और फिर वहां पे बहुत जरूरी है कि उनसे बात की जाए, पूछा जाए, उनको मौका दिया जाए कि बता सकें अपने बारे में। जरूरी नहीं है कि वो खुल के बता देंगे या बता देंगी, लेकिन कम से कम एक अटेम्प्ट जरूरी होनी चाहिए। सो मैं ये कहता हूँ कि जो बहुत सारी हम स्ट्रेटजीज और ये पढ़ते हैं रिसर्च और ये सारी चीज़ें सुसाइड प्रिवेंशन के बारे में, लेकिन मैं कहता हूँ कि जो फर्स्ट लाइन डिफेंस है ना अगेंस्ट सुसाइड इज फैमिली, क्लोज फ्रेंड्स एंड वर्क कोलीग्स, क्योंकि यही लोग होते हैं, हम ही जानते हैं हमारे साथ साथी जो होते हैं या घर वाले हों कि कुछ चेंज उनके अंदर आ रहा है। तो ये नहीं है कि ठीक है अगर आपको डिप्रेशन की आगाही है और आपको पता है कि डिप्रेशन में ये अलामतें होती हैं तो वो तो ठीक है, आप वो पता भी कर सकते हैं, लेकिन अगर आप सिर्फ ये देखेंगे कि जो उनकी नॉर्मल बिहेवियर है उससे हट के कोई चीज़ हो रही है तो कुछ वो तशवीशनाक बात है और उसको थोड़ा फिर एक्सप्लोर करना चाहिए। तो फर्स्ट लाइन ऑफ डिफेंस इज ऑलवेज इज फैमिली, फ्रेंड्स एंड वर्क कलीग्स, और जो नंबर वन सुसाइड प्रिवेंशन स्ट्रेटजी है वो कनेक्टेडनेस है। कनेक्टेडनेस का मतलब कि आपका राब्ता है किसी के साथ, और इंसान का जो राब्ता है वो दूसरे इंसानी के साथ होता है, तो पूछना दूसरे के बारे में क्या हाल है, कैसे हैं आप, ये बड़ा ज़रूरी है। जो लोग खुदकशी करते हैं या इस तरफ माइल होते हैं वो आइसोलेशन में होता है, तो खुदकशी जो है एक इज एन आइसोलेटेड एक्ट, वो तन्हा हो जाते हैं बिल्कुल हर चीज़ से, होपलेस हो जाते हैं, और उनको लगता है कि कोई ना उनके जो मसला है उसका हल है, ना कोई उनकी मदद कर सकता है। तो कनेक्टेडनेस जो है, कनेक्शन दूसरे इंसान के साथ, वो बहुत ज़रूरी है और वो हमें कभी नहीं छोड़ना चाहिए। सो ये दोनों चीज़ें हैं जो कि आप कर सकते हैं, और फिर जाहिर है फिर आप पढ़ें और दूसरों से हेल्प लें, प्रोफेशनल से हेल्प लें, लेकिन नॉर्मली जो बिल्कुल बेसिक बुनियादी चीज़ है वो ये है कि अगर कुछ चेंज आप दूसरे में नोटिस कर रहे हैं। थैंक यू।
थैंक यू डॉक्टर साहब। मेरा एक और सवाल ये है कि नॉर्मली जिन लोगों को मेंटल हेल्थ सपोर्ट की ज़रूरत होती है, चाहे साइकोलॉजी हो चाहे सेक्रेटरी हो, उनके एंड से रेजिस्टेंस बहुत आ रहा होता है और उनसे ज़्यादा वो लोग स्पेशली फैमिली, बीवी, बच्चे सफ़र कर रहे होते हैं। इन दैट केस किस तरीके से सिचुएशन को डील किया जाए?
Yasin, you want me to take that? Is it okay? या देखिए, ये बहुत आम चीज़ है और ये हम इसको बार बार फेस करते हैं अपनी प्रैक्टिस में। घर वाले आके बात करते हैं और बताते हैं कि वो बिल्कुल नहीं राजी हैं आने के लिए, दिखाने के लिए। तो उसमें यही है कि जो भी एक्सप्लोर करना होगा कि क्या कोई है आप उसके दायरे में जिसके साथ वो उसके ऊपर एतमाद है, उसको वो बात कर सकते हैं। वो कभी मामू चचा या कोई दोस्त या कोई कजन या कोई हो, उसको रोपन करना बड़ा जरूरी होता है। उनको उनको डायरेक्टली उनके ऊपर तनकीद ना की जाए, ये बहुत जरूरी होता है। उनके साथ एक रखें, क्योंकि जो सफर कर रहा होता है उसके लिए जो चीज बड़ी जरूरी होती है वो ये होती है कि दूसरे ने उसका साथ नहीं छोड़ा है। क्योंकि ये चाह तो रहे हैं, रिजेक्ट कर रहे हैं दूसरे को, रेजिस्ट कर रहे हैं, लेकिन एक्चुअली दे नीड हेल्प, दे डोंट नो हाउ टू सीक हेल्प, कैसे वो बात करें, कैसे मदद मांगे। क्योंकि मदद मांगने का मतलब है कि आपकी जो ईगो है उसको आपको कम करना पड़ता है, और वो लोग नहीं करना चाहते, खास करके अगर वो मर्द हों। तो इसलिए उनका साथ मत छोड़िए। कोशिश करिए कोई और अगर उनके जानने में है जिसके ऊपर उनके साथ थोड़ा वो एक कांटेक्ट है या एक कॉन्फिडेंस है, उनको लेकर आइए। और उनको हिम्मत दिलाइए कि किसी, फर्ज करिए किसी को दिखाना है तो मैं आपके साथ चलूंगी, फिक्र ना करिए, मैं बैठी रहूंगी वहां पे। और अगर वो नहीं भी आ रहे हैं तो किसी अच्छे प्रोफेशनल का पता करिए और उनसे आप खुद मशवरा करिए और वहां से लें, और फिर किस तरह से किया जा सकता है। तो बहुत बहुत बार मैं कई हफ्तों महीनों तक जो मरीज है उससे नहीं बिल्कुल मिलता हूँ, लेकिन उसके घर वाले आके बताते हैं और उनको मैं इनडायरेक्टली उनको हिदायत करता रहता हूँ। कभी कभी दवाई भी देनी पड़ती है वो जो मरीज है उसके जानने के बगैर, पानी में मिला के या किसी उसमें, सिर्फ इसलिए कि उसको वहां तक ले आए ताकि वो फिर राजी हो जाए करने के लिए। और मैं आपको बताऊं कि मेजॉरिटी ऑफ द केसेस में ये अप्रोच जो होती है वो काम कर जाती है, लेकिन जो इम्पोर्टेंट चीज़ है उसका साथ ना छोड़ें आप, ये बहुत ज़रूरी चीज़ है। थैंक यू।
थैंक यू डॉक्टर साहब, थैंक यू सो
Thank you so much. I'm gonna take a question from the chat. So Dr. Akhtar said, can you kindly comment on the role of AI? So he's shared an article where it says man ends his life after an AI chatbot encouraged him to sacrifice himself to stop climate change. So I guess, yeah, like if anyone wants to take that on and comment on the role of AI
Where
in the
did this
context.
happen? Where did
Okay.
this happen?
Let's see. I'm
I
just
think it's
opening up the
definitely not
article.
in Pakistan. I definitely
Oh,
think
it's a Belgian man. Yeah,
Yeah, we can
Belgian man.
forget that.
Okay, I have something to add. I hope I'm audible because my internet is very wobbly right
No,
now.
you're good.
Okay, so I have seen a lot of people using ChatGPT, AI for mental health advices, right? And I have seen cases in Pakistan where a lot of people, at least this one person that I know, they were going through a drug-induced hypomanic episode, and their go-to was like ChatGPT, right? Because again, there's like a lot of stigma to, associated with mental health, that people feel safer to, go to ChatGPT. ChatGPT का काम therapy नहीं है, because the only thing that it does is to validate your feelings and validate your emotions. It will never call you out unless you ask it to, right? And it cannot replace that human connection, because therapy का काम सिर्फ आपको validation provide करना नहीं होता. Empathy is like a very huge part of it. I'm talking about, when people need to being identified their patterns ki, okay, what are some of the patterns, and I'm not saying ki, like tha karke, but in like more, in more of a subtle way. But we aren't like huge echo chambers. We are human, so like हमें अगर patterns नजर आ रहे हैं, तो sometimes we have to have those difficult conversations, or help them improve on their communication skills and all. So there are a lot of researchers that are coming in that is like AI induced psychosis, and that is a thing that is not only happening in all over the country, but it is also happening in Pakistan, because Pakistan में mental health is not affordable. अगर और एक तो affordable नहीं है, दूसरा if you belong to like marginalized identities, then to avoid the stigma that you can face due to your identity, हमारा go-to is normally ChatGPT, and that is extremely harmful and it can be extremely dangerous. Because it is a chatbot, it is not human, the emotions are not real. So Yeah, we always like try to discourage that. ChatGPT is good for emails, but not, to replace actual human beings. Um, because yeah, I think अब उन्होंने update कर दिया है to become it like more थोड़ा cold, and like a lot of people were having difficulty to navigate through that because they were like नहीं वो पुराने वाले features वापस लेके आए where the ChatGPT was constantly like validating, and that is very concerning, and that tells a lot about कि हमारी community कहाँ जा रही है, and like how much do we lack empathy and basic human decency कि लोगों को they're scared to reach out to you, or like people in general, and they'd rather talk to somebody, um you know they rather go talk to artificial intelligence. So I have seen this happening personally, and that was like a kind of like a Black Mirror episode because obviously we were able to like point it out, and that person seeked help, lekin it was bad. So
Thank you for that, Nayab. And I'll just take 5 seconds to clarify to people that generative AI models are statistical tools that are predicting words. They're not actually doing any of the reasoning. And yeah, they reveal a lot about structural deficiencies in our society, but they should not be anybody's go-to tool. There's a lot of upcoming evidence that suggests that, of course, from high-income countries. We'll take our last question from Dr. Hira, and then we'll end. Go ahead, Dr. Hira.
Yeah, hello, can you hear me? Yeah, okay, so basically what I wanted to say was that we've been talking a lot about, what are the issues? We need to change this, we need to change that, this is wrong, this is wrong. We talked about changing the narrative and then the decriminalization. But I think decriminalization is just one of the aspects, in which we can actually bring a change. We need to talk about further other issues as well, other points, other narratives, that we can bring in, how we can bring this change. For example, Nayab mentioned about the queer, and then I added about, how there is this discrimination against addicts as well. So yes, there are these issues, but what are we doing? What can we do to bring this change in Pakistan, right? Just talking about the issues is not enough. And I think throughout the conversation, even though all of you talked about amazing points and it was so enlightening, but we did miss out, I think personally, as an audience, that we did miss out on what are the steps that we can take to actually change the narrative in Pakistan, like, for example, there is still no talk about institutionalization in Pakistan. When it comes to stigma, there is still no talk about, removing labels. So, for example, I work in Malaysia where there is a huge movement going on towards, removing labeling and how it impacts people at work. So when you are diagnosed with something and you go for jobs, for interviews, and there are talks like that, people do lose their jobs. So there is no policy, nothing in Pakistan regarding all of these things. When you're an addict, when you are someone diagnosed with a depression, with any mental health condition, so people are just removed from their workplaces. There's discrimination in schools, in universities. So there is no policy whatsoever protecting people with mental health issues. And I think that also adds to more suicide rates. So probably this is one of among the many things that we should be talking about, how to change the narrative. If anyone can, if all of you would shed some light on that, maybe discuss one or two pointers that, okay, these are the practical 1, 2, 3 steps that currently we are working on. These are the things we should be working on. As individuals, as mental health professionals, these are the steps we can take starting today to change the narrative on, suicide in Pakistan. That will be wonderful. Thank you.
I think I can take that if I'm still audible. Okay. So I think there are not exactly like 1, 2, 3 steps, like because again it depends on like it is very much contextual, right? So we talked about the decriminalization aspect of it, but I do personally and honestly think that we need to start from doing our own inner work first, right? And then moving towards community building, capacity building, having enough changes, having enough spaces, and then moving to institutions because systems are like so abusive. It's like the patriarchy, capitalism, colonialism. It's like, so much ingrained in each one of us. So it also requires to do a lot of inner work. Thinking about, and especially like as mental health care providers, we need to understand, how different layers of oppression can contribute towards a lot of abuse and suicide. Um, Suicide prevention may also look something like using the correct pronouns, being an empathetic person, giving somebody that space, putting yourself out there and speaking your truth and being your authentic self, that it gives other people a lot of that courage as well. So it's not just one thing, but it's also like, smaller things, supporting initiatives like, reducing poverty, food, because if there's like a lot of poverty or agar logon ko khana nahi mil raha, then, they're not going to talk about or they're not going to think about building communities or like usse upar, because like the basic needs are not being met, right? So it is very much ingrained, and I think we need to collectively work with like different organization and different people who are working towards these different intersections, people working with disabilities, people, the first responders. And I think there needs to be collaboration, like not us versus them kind of situation, but more of like we are in this together, because all of these things are so interconnected कि आप उनको isolated नहीं देख सकते, right? We need people coming together as a collective to work on things like together, and also including people in the conversations who belong to different marginalized identities, centering their voices. So yeah, I think that, and also like policy. सबसे बड़ा issue in Pakistan within the mental health community is we do not have a licensing body. There is no check and balance. वहाँ से there is like a lot of malpractice that is also coming in. So we can work on a lot of things together, but it is also important to, अगर individual level पे बात करें तो the starting point would be to work on, our own internal biases. Our teachers need to be educated using more of a trauma informed approach कि आप community को किस तरह से बेहतर बना सकते हो, and each and every one of us can play a role, no matter हमारा profession क्या है. We all need to do that as a collective. And sharing the responsibility, because it's not only the responsibility of like one person or like one institution or like a mental health professional, it's like everybody's responsibility. And keep talking about it, keep putting yourself out there. I think that is like some of the strongest thing that we can do, is to not be silenced. And because if we keep talking about it, then maybe even if it is like one person that I'm able to give that courage to, then it is enough for me, me personally. But obviously there needs to be more work that needs to be done. I hope I was able to answer it.
Thank you so much, Nayab. We will have to unfortunately draw to a close here. I really want to thank all of our panelists, Dr. Murad, Fatima, Nayab, Dr. Tayyeba, for having this conversation with us, with the audience, and of course, going 25 minutes over time. Thank you so much for that. I'm also super grateful for Alia and Aruba and the Pakistan Mental Health Coalition for arranging this webinar for us, and of course, Gul, you've been the creative force behind this, so thank you so much for that. Gul's also put into the chat some helplines that you can reach out to, because I know a lot of people tuning in might be struggling with suicidal ideation, so that's one thing that can help. Gul, if you could just paste that again, that would be great. And thank you, everyone. Take care. Allah Hafiz. I'm keep getting weather alerts about how it's raining again in Karachi, so stay safe and have a great
Thank you,
rest of the day.
everyone. And thank you, panelists. Thank you so much. It's been great.
Thank
Thank you so
you.
much.
Thank you for
Thank
having
you.
us.
Thank
Allah
you.
Hafiz.
Hafiz.
Thank you
Bye.
Allah
so much.
Hafiz.
Hafiz.
Allah Hafiz.
I'm also going to hop off and join my meeting. Okay, thanks, Essen. I appreciate it.